Okay. So thank you so much. I really appreciate your time.
Thank you for having me.
Of course. So can you tell us a little bit about yourself, and why are we talking now?
Oh, yeah. So, my name is Brooke Winner. I'm a fellowship trained minimally invasive gynecologic surgeon. I'm originally from Alaska. I did medical school at University of Washington in Seattle, and then I went to St. Louis, Missouri for residency, fellowship, and I was on faculty there for about 4 years. And then I moved back to Seattle, and I've been employed by a Swedish hospital for the last about 5 years. And now I'm in the process of opening my own private practice, full spectrum fibroid and endometriosis. And we are going to be focusing on both expert level minimally invasive surgery as well as longer term follow up of these chronic conditions. And we are putting together a multidisciplinary team, including a dietitian who's going to see patients here 1 day a week, an acupuncturist who specializes in women's health and fertility, who's going to be here 1 day a week, and then we have some pelvic floor physical therapists and mental health folks that are going to be working with us closely as well. I'm really excited about this concept. There's not a lot of multidisciplinary clinics, endometriosis patients in particular. Um, Sometimes they can find good surgical care, but the aftercare piece is what's missing. What I was hearing from my patients, they didn't feel like they had someone to follow them long term, and their surgeons just wanted to do surgery. So we're putting this all together.
That's awesome. So when I heard you're doing it, I was very excited. I really believe we have such high demand and need for centers like what you're building, like the multidisciplinary approach and like having experts focus on endometriosis and related conditions. I in my analysis, since we are seeing 200,000 new patients per year, I mean we did a lot of mathematics to get to 200,000 ballpark, and if we consider every like 300 patients can be operated on by one surgeon, we need about 600 or 700 centers. And we know by experience that these centers cannot be like general OBGYN or anything. It needs to be dedicated to the disease.
Yeah.
So super excited for what you're doing. I wanna take one step back just to let you know this conversation will cover like many things, not just centers, not just endometriosis. We'll talk a little bit about yourself as well, and you can share more about your non-medical side if you are interested, if you are
Yeah.
comfortable with it.
I'm game
Yeah,
for whatever.
awesome, cool. So let me start with this. Why do you live in a boat?
Well, that's a great question. I was dating somebody long distance when I was still in St. Louis who lived on a boat out here. And he said, move to Seattle, move onto the boat with me, save a bunch of money, pay off your student loans. It'll be a fun adventure. And it has been. It's been great. It's so beautiful. We're on the Puget Sound. We're all the way at the end of the dock. And so we have like an unobstructed view of the Olympic Mountains, and there's eagles and seals swimming around. I see that when I'm making coffee in the morning. So it's just the sunsets are incredible. And we can just go right outside the marina in our dinghy and drop crab pots and then come back a few hours later and have fresh Dungeness crab for dinner. So it's, and then of course you can take the boat to the, up to the San Juan Islands or up to Canada. We took my parents all the way up to Canada last year on the boat. So, um, it's been, it's been a really cool experience. And my family thought I would only last less than a year on the boat, and it's been like 6 now. So
Wow,
still loving it.
I love it. You are living my dream life. I
Yeah.
have to tell you, I'm really hoping to get there.
There are some less glamorous parts, like the bathroom could be a little bigger. I would like that, and
Mm.
not having a garage, and not having a washer and dryer on the boat. You have to take that all the way up to the top of the dock, and it's a shared laundry room. So it's not all glamorous, but it's, to me, it's worth it.
I completely understand. It tells a little bit about you, however. I told you I have another friend, another endometriosis surgeon, one of the best ones. He lives on a boat, and I have spoken with other endometriosis surgeons. They all have like something not common. Like you can point out, like it's obvious that that's not something that everyone does.
Hmm.
It's not like subtle, like difference. It's a I
We
it
like to break the mold in all areas of our life.
right. That's
Yeah.
exactly what I was thinking. Like these people are different. Their brain is
Disruptors.
different. Yes,
Disruptors in a good way.
exactly. Like disruptors. They don't want to follow like whatever everyone is doing. Like you didn't want to follow. You could do like whatever lifestyle that you wanted as a physician, but you chose this one, which is
Hmm.
fun and great, but not something that most people choose to do. So
Yeah.
it's a so you agree that you're a disruptor, right?
I don't want to get in trouble, but yeah, yeah,
No, disruptor in a good way. Look, we
yeah,
live in a world that is built by disruptors, in
yeah,
my opinion.
yeah.
And
I think it is hard being a woman. I'm not going to lie in this space. I mean, it's a it's an uphill battle sometimes because it's hard for people to understand why you're doing things differently, and it's hard to not for other practitioners not to take that as a criticism of what they're doing. And in some ways, maybe we do need to have those tough conversations, but it doesn't always make you popular.
yeah, so because you mentioned that, that was something that I wanted to bring up later. That I mean, based on the stats, most of the surgeons, especially in advanced surgery field, especially in endometriosis, the ones that we consider as top ones, are
Hmm.
male.
Hmm.
And being a female in a male dominant space, although it might be changing now, I agree there are changes, but it's not there yet.
Hmm.
Um, do you feel intimidated? Like how does it feel to be in that space?
Um, well, that's a great question. I think that by the time I moved to Seattle, I'd been in practice for 5 years, so I was pretty confident in my skill set. It was scary coming to a new city and trying to do really difficult cases, right off the bat. And so it took, I just feel like it takes a little more pushing for sort of women to get the support that men are just automatically given. And in the process of pushing, you are perceived as aggressive or a bitch or whatever. And you might be saying the exact same thing in the exact same tone of voice as a male surgeon. And the thing is, the male surgeons don't have to be pushy, right? Because people are just falling all over themselves to like give them whatever they need. So in a way, we are being pushier than the male surgeons just because we have to get the care that the patients need. So that's been stressful, but I think it's important to, just be like, kill them with kindness, be nice, but be firm. These are complicated cases. We're going to need these things. This is not like what everybody else is doing. So, yeah, it's a fine line to walk.
Yeah, yeah, and in some sense it sucks because instead of focusing on like what you want, you have to focus on a lot of politics,
Yeah.
which takes so much time. And so let's now that you have taken this path to be one of the rare female top surgeons in an area, especially in Seattle and in Washington in general, there aren't many top surgeons for endometriosis. Maybe you and another one, and that other one is also a female that I know. So, but let's take a few steps back. What brought you to this spot? Like you started medicine because of what?
Yeah.
Then you started medicine. Then you started OB-GYN. Then you thought I want to do AAGL. Like I want to do a minimally invasive fellowship. Can
Yeah.
you walk us through like what was the defining factors that you made those decisions? I'm very curious about that part.
Yeah. So, oh man, this is like the way back time machine. So, I always knew I was interested in women's health, but I did not think I would like surgery, which is kind of funny because that's all I do now. Um, I was just kind of squeamish, like blood bothered me. I just wasn't like a very, I don't know, I was a pretty timid child. But I liked science growing up and I liked women's health. And eventually I decided to go to medical school because I liked my biology classes at Stanford the best. Did the human biology major, which is like a cool major that combines basic science and social science and kind of marries them up. It was really neat. Um, And Chelsea Clinton was in class with me. She was pre-med for a while. She was in my dorm, so that's a fun fact.
Wow.
So anyways, fast forward, I'm in medical school and trying to decide on a specialty. And I was in Alaska whammy, which meant I did my first year of medical school in Alaska, and then my second year in Seattle, and my third and fourth year mostly back in Alaska. I did a home track, and I was doing my general surgery rotation up in Fairbanks, Alaska, which is in the center of the state, which gets really cold in the winter. It was like, I remember it was like -30 when I was driving to the hospital. And I was working with these like sort of old cowboy surgeons, and there was nobody else there, right? No other medical students, no residents, nothing. And I remember like one of the first days, the attending started like telling me like how to hold the scalpel, and I was like, why is he telling me this? And then he like let me do the appendectomy, which was being done open on a child, Fairbanks, Alaska. So it wasn't like the most cutting edge medicine, but I was, one on one with the attending. And I realized that surgery was not a bloodbath. If it's done properly, it's like actually very neat and tidy and like aesthetically pleasing if you're doing it right. So that was sort of eye opening. And it was interesting because like my fellow medical students who were back at UW, they were like, seeing a minimally invasive Whipple or, something like cutting edge, right? But they were on like 6 risers in the back row, like they couldn't even see, right? So it's just sort of interesting, that dichotomy. But anyway, so I decided that surgery was not terrifying and that I actually liked it. And so that made women's health and OBGYN easy because, I was thinking, well, I can't do OBGYN if I'm not going to like surgery. So, and I liked my personal statement applying to OBGYN residency was pretty much like everybody is like, right? Like delivering babies is amazing. And then you get a little bit of everything. You get the long-term continuity of care and you get to do a little surgery, but not all surgery. And everybody's friendly. So, that sounds great. As I went along in my training, I just kind of felt like surgery is really complicated. And if I'm going to do it, I want to do it really well. And I was planning on moving back to Alaska at that point in time. And when I was operating with some of my general OBGYN attendings in residency, if there was a difficult case, they would frequently call in the gynecologist, not because it was cancer, but just because it was complicated and they needed help. And at that time, there was actually no gynecologist in Anchorage, Alaska, where I was from. So I was like, what am I going to do? Who am I going to call? And they're like, oh, it's fine. You'll just call general surgery. And I was like, do they know how to do a hysterectomy? Like, it just felt weird to me to be in a situation where I still didn't feel confident doing something as scary as surgery. So I decided that if I was going to do it, I wanted to do it really well. And I just kind of figured out that volume was really important and that it's really hard to have high surgical volume when you're doing a lot of primary care and a lot of obstetrics. And I liked delivering babies, but I also like sleeping at night. There's not a lot of hysterectomies done at night. That was my path. They just sort of founded a minimally invasive division at when I was a chief resident. So it was all kind of brand new, but very exciting. There's a really skilled surgeon that I basically did an apprenticeship with most of my training, and it was all straight stick laparoscopy. So I don't use the robot, which whatever, the robot's fine. It's just a tool, but it's easier to get block time if you don't need the robot. The incisions are slightly smaller. There's fewer of them. So that's just my straight stick plug real quick. But so that's how I wound up where I'm at.
That's amazing. So and then you ended up not going there, but you did that fellowship.
Yes, I ended up not going back to Alaska because much to my parents' and my brother's dismay, I was just worried the population wasn't big enough, and that even if I found a group that would let me be GYN only, that might just be a lot of, pap smears, and I think I have a yeast infection, that kind of stuff. So there actually has not been a fellowship trained minimally invasive surgeon in Anchorage until just recently. One of the recent Harvard fellows just moved back there. So I'm excited to talk to her at AJL about how it's going.
That's awesome. So basically, but that was at least a motivation for you to do the fellowship. And then you did the fellowship, came to Seattle, and so when you moved to Seattle,
Well, I did the fellowship and then I was on faculty for 4 years. So I, like designed a dedicated minimally invasive surgery rotation for the residents that was just sort of all wrapped into the general gynecology at the time. So we pulled it out, made it a dedicated not elective rotation. And then we were running the surgical skills program. So like simulation with like FLS. So back then it wasn't required. So we were one of the first programs actually incorporating fundamentals of laparoscopic surgery, which was a general surgery training tool, into OBGYN training. So that was neat. So we were teaching residents to suture back when that wasn't super common, especially straight stick. So yeah, so I was doing research, I was teaching a lot, and I was operating. And then after I had, 4 or 5 years under my belt, I felt like I was, because even well, I guess everybody's different, but even when you get out of fellowship, you still need a lot of support. And it was easier to just be at the same institution where I knew everybody. After about, 4 or 5 years, I felt like, okay, I can go to a new place. So
I
I admire all the fellows who are just going somewhere brand new, like straight out of fellowship. That's got to be very difficult.
was this the same center that Patrick Young and Jose Eugenio?
No, he was at the other center in St. Louis.
Oh, oh, okay, all right.
Yeah.
So about the 4 to 5 years, there is a study in Harvard Business Review that it takes one 5 years equal to 10,000 hours to
Yeah.
become a true expert in something that they
Yeah.
want to be an expert in. So I completely agree how you need that 4 to 5 years before you feel like totally comfortable about being an expert in that space.
Mm-hmm. Mm-hmm.
So then you move to Seattle. So can you share a little bit how your transition into your focus on endometriosis and related conditions? How that was growing in this journey that you have had through all this process?
Yeah. Um, well, in my practice at WashU, I was still doing some general gynecology, so I would still do annual exams, and I mean, really anything a patient wanted to be seen for GYN. And then when I moved to Seattle, I took over. I was actually employed by a private practice GYN oncology group initially. I was one of two benign folks there, so I took over from a gentleman who had sort of an older patient panel, mostly menopause and routine care. And so I kind of had to work to morph that into a more surgical practice. And I just kind of built it up over time, slowly cut back the number of annual exam slots I was seeing, and then started narrowing the types of problem visits I was seeing once I was only seeing problem visits. And then at a certain point, I was just only seeing patients who were coming in to talk about surgery. Not that they had to know they wanted surgery, but at least, they were coming to talk about that. And you know, big fibroids and bad endometriosis are really the only cases that general OBGYNs are going to refer, right? Like they're not going to refer the easier stuff. So it just sort of happened to be that. I mean, the fertility doctors and the general OBGYNs were my main source of referrals at the beginning. And then I've always, I've always paid attention to my like online presence, but I wasn't doing social media back in St. Louis. So I just started like paying attention to my Google and my health grades and my Yelp and my whatever. Um, and eventually my wait list was so long that more of my patients were just finding me online, and the fertility doctors and the OBGYNs were referring to people who weren't booked out so far.
Mhm.
Um, so yeah. But even then, I mean, patients aren't going to wait 6 months to see you if they've got a problem that, somebody else could take care of. So it's just sort of a self-selecting process, whether it's referrals from other doctors or from patients. And there's just such a big need, right? Like women with fibroids are told all the time that hysterectomy is their only option, when I think myomectomy is like super underutilized, and we can do almost all myomectomies, minimally invasively these days.
Mhm.
And now there's the new radiofrequency ablation of fibroids assessa. So that's something new on the horizon. So there's a need with fibroids, especially big and numerous fibroids. And then obviously endometriosis is just very technically challenging. The GYN oncologists say that it's more difficult even than their cancer cases, just because of how inflammatory and fibrotic and invasive the cells are.
Mhm.
Um, so yeah, I think I didn't really. It was kind of engaging with the online community, honestly, that sort of showed me like I was taught to excise endometriosis, but I never thought about it. Like I never, it wasn't really like in the front of my mind that that's what I was doing and other people weren't doing it until I started like engaging in all these Instagram with other doctors and patient forums and stuff and realized that like patients were specifically seeking this out. And I was like, oh, I do that. Like I kind of just thought everybody did who did a fellowship. I don't know. So anyways, it just sort of like crystallized in my mind, like what I was doing, what the need was, what patients were looking for, and then slowly we're getting more and more data about outcomes being better. So um, I guess, sorry, that was a very long-winded answer, but that's how that all evolved.
That's exactly what I was curious about because there
Yeah,
is no I'm pretty sure there is no like a straightforward path. Okay, you did the OB-GYN, now let's do endometriosis excision surgery because it's not that clear. It's like
yeah,
as you said, even patients go through multiple steps and
yeah,
stops to get to
yeah,
the right person.
yeah,
So and providers are trained in that same system. So I think I that's a, so you kind of basically found yourself in this space.
yeah. And actually, one more thing is important. So the minimally invasive fellowships are so diverse, and some of them are run by GYN oncologists, some of them are run by like urogynecologists, and that's changing. There's a new requirement that the program director has to be a fellowship trained minimally invasive specialist, I think starting maybe next year. But not all fellowships are heavy in big fibroids and bad endometriosis. That's just like who I trained with. Um, so um, it's just interesting. And some fellowships are very hysteroscopy intensive. I think there's like maybe one or two that does a lot of vaginal surgery. So yeah, so that is, and training with GYN oncologists is great. They're obviously awesome surgeons, but they, are ideally they're mostly treating cancer, right? So if you do your fellowship with them, you're not doing as much endometriosis. They do quite a bit, but they don't do as much fertility sparing. In my experience, they're a little bit more likely to not really believe in trying to get it all out because there is hormonal suppression options available afterwards versus cancer, right? They would be like really trying to get it all out. Um, so where somebody did their fellowship and what type of surgeon they trained with and what cases they were exposed to in fellowship is really important. And I was just exposed to super big fibroids in St. Louis, a large African American population, really, really big fibroids, and also terrible endometriosis, like with colorectal surgeons and urologists and like the whole endometriosis protocol, MRI, like the whole 9 yards. Like that was my fellowship. So that set me up to be able to do it afterwards. So this is very hard to learn on your own outside of training.
I see. So you come out and come out of the fellowship, do that thing in St. Louis, then come to Seattle, join the Sweden hospital, start developing your practice and brand, getting a lot of patients with endometriosis,
Mm-hmm.
and you were like a low light surgeon. Like basically, I didn't even know your name or I didn't hear from about you from anyone, although you were having this big fan base and patients in Seattle. Because probably you didn't know, you didn't need that. People, you were already, that's in our previous conversation, um, busy doing all these surgeries and like medical care. Like you didn't have time to do these other things that you could do,
Well, and
right?
I wasn't doing research. I would like to start um, a database like we had back in St. Louis here, but that's hard to do when you're not in an academic setting. So, I mean, that I feel like a lot of the surgeons that people know are publishing. Maybe that's not true.
Okay.
Yeah.
And then kind of I can understand what was happening. Then what happened that you decided now is the time to transition out of that practice and focus on building your own center? What was the decision factors there?
Um, it was complicated, but being employed by a hospital has pros and cons, and I was always somebody who had very strong opinions about how I wanted my practice to run, and that's just not how it works when you're an employee. So um, it's been both terrifying and fun to be making all the day-to-day decisions about how the clinic's going to be set up, who's going to be seeing patients, what's the schedule going to be, what's the atmosphere in the clinic going to be like. So, yeah.
So I spoke with other friends and experts who have launched clinics. One of the like their biggest problems typically come out of I was rushed to see patients like in 10-15 minutes blocks, so I would probably they couldn't connect with patients the way that they wanted.
Yep.
Or in the OR they had this limited block time to do this amount because they were counted. The
Yep.
RVUs, the performance, uh, I would assume similar situation is a typical situation in most centers. I would assume similar situation could be pushing any surgeon out of that state. Like they want to do more, but the system is not built to do more for each individual patient. Do you agree? Do you agree with that mindset?
Yeah. I think that's a common complaint from employed physicians. Um, I mean, to their credit, I actually had a fair bit of flexibility in over my clinic schedule. And over the years, I built up quite a bit of block time so
Okay.
that, but yeah, it just, in a big system, it takes a long time to make any changes. And I also want to be careful because I'm going to be operating at the same hospital. So there's a lot of great things about their OR and the way it runs. And I want to maintain positive, healthy relationships with everyone there. Um, and yeah, I mean, starting a private practice is not for everybody. Some people would rather just clock in and clock out, and if not worry about having to market and attract patients and manage staff and like all that. So definitely not for everybody, but certainly in this setting, we're more agile and we're more able to respond to what patients need
Mhm.
in a sort of nimble manner.
Awesome. So when is the practice going to be open to patients, or has it been opened already?
No, we're uh, getting a couple more malpractice quotes, trying to find the best deal. And then once that's really the last piece of the puzzle. And then we're hoping to open in November, but next week Nicole and I are going to AGL, and the following week is Thanksgiving. So I think we're not going to start seeing patients till December, but we haven't announced official date yet.
Okay, awesome, very cool. So I wanna ask and focus a little bit on your practice and the philosophy that is going to shape your practice and the future of your practice.
Mm-hmm.
So you call it full spectrum, and in our previous conversations, it's my understanding that your focusing is on building a true multidisciplinary care plan in your own word.
Mm-hmm.
And So when you say multidisciplinary, there is two type of multidisciplinaries. One is multidisciplinary OR team, which means like you have a general or colorectal urologist or other surgeons that are needed, and then you have a multidisciplinary for pre and post surgical care.
Mm-hmm.
Can you tell us a little bit about first? Maybe start with the OR. What are you doing? Who are you bringing in your team as your like staff, like as your colleagues in your OR,
Yep.
and then tell us more about your before and after surgery care plan with the multidisciplinary team that you initially explained about the dietitian and
Mm-hmm.
acupuncturist. I would
Yep.
love to hear that. I'm very passionate and excited about this trend of the practices that,
Mm-hmm.
especially I think you are one of the first ones that are actually launching something like this.
Yeah. Yeah. So in the OR, I was working with a colorectal surgeon and a urologist, and they had big groups, but I really just wanted to kind of keep it a single point person because it's just easier and they grow to trust you. And, I frequently have colorectal on backup and not usually need their help. But so it's just easier for both parties if it's more of a personal relationship versus just whoever's on call for the group. So I built those relationships when I moved here, and I knew I was going to be doing these challenging cases. I also brought with me the endometriosis protocol MRI that we were using at WashU, and I found a private radiology group here in town that had machines that were like nice enough to take the thinner cuts in the rectovaginal septum, and they were happy to adopt the protocol and start doing all of my MRIs. And they were doing my fibroid MRIs as well. And so I was just on the phone with those radiologists, just like constantly looking at images with them. So I got to know them really well. And then actually, University of Washington developed an endometriosis protocol. Sort of, they're calling me like, "What is this? And why is it better?" So then they started doing it, which was great. There's patients had two options for getting a high quality endo scan like that. So that was kind of, I was already multidisciplinary in that sense, like basically ever since I moved here. Um, but it was really the clinic follow up piece. If patients were referred by their general OBGYN, then it was easy. They were happy to go back to that provider because they had, recognized their limitations, referred to me, and now they're going back. But it was the patients who just felt like they hadn't been heard for a long time by their, primary care doctor or their regular OBGYN or whoever they were seeing, and they had to like do their own research and find me on their own. And then after surgery, they were like, "Who do I go back to? I don't want to go back to who I was seeing." Um, and I didn't like have a great answer for them. I had a nurse practitioner. Well, at first I would see them myself, right? But then I got busy enough that I was only seeing surgery. But the nurse practitioner was she was also helping me with pre and post op, so she was just getting too busy, and she was shared with my partner. So, anyways, that was the main, like, where are these patients going to go? That was the main impetus for the clinic idea. And then I'm on a lot of online Facebook endometriosis support groups, and patients are always saying, like, why is there not a comprehensive endometriosis treatment center in Washington State? Like, what is going on? And I've given a talk on surgical excision of endometriosis, improving pre-op prediction and reducing unwanted surprises, which was a very popular title for that talk. I got a large attendance at that, which was fun. But in the process of doing research for putting together that talk, I actually found a multidisciplinary clinic at, I think it was UCSF, and they talked about having a patient navigator and all the multiple modalities. So I kind of used that a little bit as a model. And then in terms of like who to pull in, I mean, patients would ask me all the time, like, what should I eat for, endometriosis symptoms? And I was always like, I don't really think there's any good data that shows that anything helps. And then I started talking to dietitians. I was like, oh, that's not actually true. Same thing with acupuncture. I didn't really know much about acupuncture. And then I realized that my fertility colleagues who are going through IVF themselves were using acupuncture and recommending it to their patients, and actually had an in-house acupuncturist in their fertility clinics. And I was like, oh, this is much more legit than I previously. So I've learned a ton as I've like been putting this all together, who to bring in, what's the data. So it's been great. I've been meeting a lot of people. It's been really eye-opening for me. And then for them, they're going to come observe in the operating room. I've given them my talk, so they've seen my videos. So it's been really fun to cross train like that. And I think that the team is strengthened when we all are more educated about what each of us are doing.
That's super cool. In some sense, I don't, you might know that you are really disrupting this space in the sense of bringing this like multidisciplinary post-surgical care into your office. I'm
Mm-hmm.
not saying it hasn't been happening. It has been happening, but in like a piece. Like, for example, I know surgeons who do the follow-up annuals for their patients because they want to keep that connection.
Mm-hmm.
But bringing the dietitian, bringing the acupuncturist, it's another level of like multidisciplinary care
Mm-hmm.
in the practice.
Mm-hmm.
There is a school of thought out there, especially some advocates advocate for that school of thought, and some surgeons might really believe in that, but surgeons probably less. That excision is the answer to everything about endometriosis, right? You do the excision. So if you have a symptom after excision, do another consult, then do another
Yeah.
but now recently there is more openness to, okay, excision is step one in a process.
Mm-hmm.
Now you are basically trying to build that process, knowing that you do your own excision in as a step one. um, so I imagine you're gonna see some pushbacks or maybe some questions about what you're doing, but in my opinion, I totally agree with you that there is a big need for it in my personal analysis of the patient's behaviors and like what patients are going through.
Hmm.
So I think I really appreciate what you're doing. That's a really great concept, and if you can, when you make it really successful and work, many people will follow the path, in my opinion.
I hope so.
Awesome. So I want to focus a little bit on your surgeries and excision of endometriosis philosophy, right?
Hmm.
So there is a debate out there about the definition of endometriosis and how it's created. I don't want to get into that. That I don't think there is clear scientific evidence to define if it's endometrial, how it's endometrial like, or if it's genetic or it's like retrograde.
Yeah.
It's not something that you can now answer. There's evidence, conflicting evidence. So we're not getting into that. But about the surgery, actually, the surgery like philosophy. So a lot of patients are very passionate about saying endometriosis is not retrograde
Hmm.
menstruation because they want to get away from hysterectomy,
Yeah.
and they think hysterectomy has been an answer to a question which was the wrong answer for a long time.
Yep.
And I just saw an advertising for one of the panels on AAGL that when hysterectomy is feasible or like is needed in an endometriosis surgery.
Hmm.
So can you tell us more about that? Like, what's your philosophy of basically excision and hysterectomy, and like when that's needed in
Hmm.
your care and in your philosophy?
Hmm. Um, so I do think, I mean, you're right. We don't know really the etiology of endometriosis, but I do really like the embryologic origin theory because, you know, there's like basically a duplicated reproductive system that fuses. And so there's a lot of moving parts and cells moving around. And it's easy to imagine how some of the endometrial cells might wrongly migrate and become endometriosis cells. And it's very common for patients to say that their periods have been terrible ever since they started. So I do think that is definitely at play. It might not just be one thing. Um, but the nice thing about that theory is that if it truly is embryologic origin and you are able to get it all out, it shouldn't come back. In reality, we see even with good excision surgeons that operate on patients that had surgery with another good surgeon, we know that it does somehow still seem to come back, and maybe it's like the cells were there, but they're maturing at different rates. Who knows? Um, but um, I think that's important in the surgical philosophy. Just for me, it just really adds another level of urgency to be dedicated to really trying to get all visible or palpable endometriosis out. Um, when to add a hysterectomy is complicated. I mean, patients who have endometriosis are much more likely to have adenomyosis, and that might not be detected on imaging, right? The only way to definitively diagnose this is pathology after a hysterectomy, but sometimes it can be suggestive based on the ultrasound or the MRI or even the appearance of the outside of the uterus on laparoscopy. Um, and so, um, if patients have adenomyosis, then adding a hysterectomy to the excision of endometriosis can give them better pain control and longer lasting pain control. And even in patients who don't have adenomyosis, there just seems to be something about the inflammation from endometriosis that makes the uterus and the cervix more tender. So, especially if the uterus or the cervix is tender on a bimanual exam, I think that increases the chance that adding a hysterectomy will give them improved pain control. Um, I think the hysterectomy got a bad rap because that was all people were doing, right? They were leaving the rest of the endometriosis behind. And so I think the endometriosis community is maybe like pendulum swung a little too far in being anti hysterectomy when we know that it does seem to provide some benefit. And there was a paper in the Green Journal, I don't know, maybe 6 or 7 months ago, a big French series where patients who had a hysterectomy as part of their like high quality excision surgery were much less likely to go on to have another surgery. And that kind of that reflects what I've been observing as well.
I really like that philosophy, especially the last part that you said, the inflammation piece, because there are startups like top startups that have the top-notch scientists, Harvard grads and Stanford grads and MIT grads, people with real like vision and understanding of the molecular and biology doing these startups, and they are really seeing difference in molecular like environment of uterus in endometriosis versus non-endometriosis patients. So obviously there is clear like biology and molecular changes there. So I completely agree. And then thanks so much for sharing that about your philosophy. I was really curious about what you think because it's a common question that usually there's a lot of debates and disagreements, or maybe like still not complete agreements between surgeons. I
Mm-hmm.
was curious about what you were thinking about hysterectomy.
Mm-hmm. Mm-hmm. Yeah, I mean, obviously, if someone wants to be pregnant in the future, or if they're not sure and they don't want, they can't decide right now, then you shouldn't do a hysterectomy. But I just lay all the options out and you know provide my opinion about which would be the most effective, and obviously, it's up to the patient.
Yes, that's very cool. So I wanna now ask a couple of personal questions for us, to me personally, and whoever listens and watches the podcast, to know more about you. When you are not working or building your practice, what's your thing? What fun thing do you do for yourself?
Um, well, I live in a really beautiful area, and so I like to just like hike in the parks around Seattle and walk on the beach. I'm right next to the beach. So like in the summer I'll just like go on a walk in my flip-flops, and I'll take off my flip-flops and just like walk in the sand and the water. It's just so relaxing. I had a schedule where I was doing telehealth from home one day a week at one point, and so then I extended it an hour later in the afternoon so I could take a 2 hour lunch so I could just go on a walk. And it was such a nice thing to do in the middle of the day, especially after just sitting in front of Zoom calls all day long. Um, and then we do a lot of like crabbing for Dungeness crabs. We go to the coast and we dig razor clams. There's a spot prawns season that's one day out of the year, and we go catch spot prawns, which are delicious. So we do a lot of outdoor stuff like that.
Awesome. Is hiking your exercise? Is that what you do for your exercise and your body health?
Yeah. I used to run a lot, and I kind of stopped when I moved here. And I've tried to get back into it, and I keep injuring myself. So that is frustrating. But I guess that's just maybe getting older. I don't know. But yes, I'd like to get back into running, but for now, walking. And I think walking is great for mental health. So is running. So they both have their place.
Yeah, I'm glad that you're doing it. Half of the surgeons that I speak with, they don't exercise. They consider doing the operation, standing and doing the operation an exercise because they don't have the time to do any other exercise, which I disagree. I think
Yeah.
exercise, you need to be like in your space, have your own time for yourself. That's a different thing than just. But I'm glad that you're doing that for yourself.
Yeah. I should do it more.
Yes. What keeps you up at night now? I know you're launching the practice. There are a lot of moving pieces. So
Hmm.
at this moment, for now,
Hmm.
like right now, like
Hmm.
maybe what's your biggest worry that you're thinking about?
Well, I'm actually sleeping better than I was um,
Good sign.
previously. But yeah, I mean, there's a lot of little details about, I mean, just like even down to the like getting the online scheduling system to work and syncing up there's just a lot of tech stuff at the beginning that needs to be set up. Um, so that's stressful. And then um, we're out of network, so that's new. And I don't love having to do that, but I have a long explanation on our website about why, and a lot of endometriosis surgeons sort of have similar stuff. Um, so that's, you know, I resisted doing this for a long time because of that, but it's just unfortunately kind of the only way to be independent these days. Um, So just, I mean, are there going to be enough patients, right? I'm going to be able to pay my rent, pay my staff. I've got a full-time office manager. I'm employing Dr. Nicole Kretzer, who's wonderful, and I love her. And she has basically done an informal fellowship with me for the last 3 years, and now she's joining me in this practice. Um, she's also worked with a urogynecologist during that time, so she has a really sort of broad pelvic experience, and more um, like different modalities like bladder Botox and pelvic floor Botox. So she's going to bring a lot of cool stuff to the practice, also with like prolapse and incontinence surgeries. But yeah, I mean, so that's like a really big responsibility, right, to make this work for these people that are depending on me. And I think it's going to be fine. But you're always a little worried.
Yeah, I agree. That's I think a part that a lot of people don't see, especially there are some people with or without agenda go after a surgeon and say all the things that is not necessarily true about the surgeon. They don't think like this person has put a lot of things online to serve patients, and then like trying to make this surgeon go through hell to make the practice work is not
Mm-hmm.
going to help anyone. These are human beings. They could make other decisions. They could be working somewhere else, having
Mm-hmm.
fun, no
Mm-hmm.
responsibility, but they took responsibility to disrupt the market,
Mm-hmm.
and they are anxious about making it work.
Mm-hmm.
But now I'm trying to make this practice and person to fail because of whatever reason. I think that's a piece that I'm really like sometimes I personally get angry about when I see people talk about a center or a person, a surgeon, without having enough evidence or basis to talk about that.
There's a lot of anger in the endometriosis community because patients have been ignored for so long. And I understand that. I think you're right. A lot of times it's not fair to surgeons, but I, I understand why that's happening.
Yeah, yeah, I understand. Also, similar to probably less than you, but also I understand that. But I think if there is no innovation and there is no disruption, then we are not going to see any improvement and growth in the space. And but that also doesn't roll back the time for the people who have been under trauma and are angry. So there's no easy explanation or solution to this. But I really hope that this works because this could be one of its kind. In like you are launching something very unique,
Yep.
and I'm really hoping that it works. So we all learn from you, and we'll see how you grow. And so, what are you hoping for to achieve in the next 10 years?
I want to hire more surgeons. There's a lot of minimally invasive fellow graduates who can't find jobs that are GYN only. Some of them are doing OB, which just, again, it's hard to maintain your skills in that sort of a practice setting. And even the ones who get GYN only jobs, a lot of them are still doing a lot of general gynecology. And so to be able to have a practice that's busy enough surgically where you can give another surgeon the leg up so they can really do what they were trained to do, because you need to solidify, even after a fellowship, you need to solidify that skill set like right away. You need to be doing a lot of surgery right away in those first 5 years to get good. Um, so I'd like to hire other surgeons. I'd like to hire some nurse practitioners, and I'd like to eventually expand to a bigger clinic because we're going to run out of space really quick if we're bringing in all these different acupuncture, dietitian, pelvic floor. Um, I've got a couple other colleagues that have started their own out of network practice. One is a general OBGYN doing OB, and the other is a menopause specialist. So it'd be cool to have a building where we all had our practices that were separate but together, and maybe like a physical therapy floor, that kind of thing. So that would be like the 5 year plan.
I think that's great plan. There was a study. I think it was stated that there are 160,000 endometriosis surgeries being performed every year. So, and now, in my opinion, we don't have over 100 qualified endometriosis surgeons in the U.S. I
Mm-hmm.
mean, of course, everyone from legal standpoint can cut the patient open and do, but people who can actually deliver like good outcome. And so, if you can bring more surgeons and train them, we need, in my opinion, up to 600 surgeons focused on endometriosis. That would be amazing. Like that would be so cool, and you will help a lot of patients by expanding your clinic and bringing more surgeons.
Mm-hmm.
So I'll be definitely supporting you and cheer you up. I hope you can achieve that.
Yeah, it's very exciting.
Yes. Any last word for me or for whoever is listening, which will be providers, patients, PT, surgeons, a lot of different specialties listening to these podcasts.
Yeah, so extremely painful periods that are disrupting a patient's life are not normal. Please send them over. Even if they haven't been diagnosed with endometriosis, we're happy to see them. If they're having a ton of pain, they probably have endometriosis. And our website is fullspectrumgyn.com. And my Instagram is dr.brookwinner. And what else? Our clinic email is info@fullspectrumgyn.com. So feel free to reach out if you want to become a patient or refer patients, or I'm happy to be a guest on other podcasts. As many people as we can spread this information to, the better.
Thank you so much, Dr. Winner. I really appreciate your time.
Thank you so much. I appreciate you having me.